All right, let's dive into rheumatology and orthopedics.
Mhm.
You guys wanted the full chapter summary, and it's a beast, but we've got our expert here.
Ready to tackle it.
We'll hit those key theories and concepts, maybe some research, case studies, the whole 9 yards.
Sounds good.
Explain it all clearly. Real-world examples, practical stuff, you know the drill.
Gotcha.
So first up, something most folks have heard of, osteoarthritis, OA.
The big one, especially as we get older.
Way more than just a little wear and tear. Most prevalent arthritis out there. All about what's happening in our joints, that articular cartilage.
Right, not just knees and hips. Even the spine gets involved, surprisingly.
Huh. Always thought it was just those two. But okay, so articular cartilage for OA to make sense.
Imagine like a door hinge, smooth when oiled, right? OA, the cartilage, it wears away.
Yeah.
Bone on bone, that's the pain, stiffness, the cracking sound, crepitus.
Ouch, makes sense. And get this, it's often happening before you even feel it. 90% of people over 40, x-rays show, OA, pain or not.
Wild. Sneaky, huh? So the big question then is, can we do anything? Stop it, reverse it?
Yeah, that's what I'm wondering.
Well, that's where it gets tricky. Can't really cure OA. Cartilage damage, it's mostly irreversible. Doesn't mean we're helpless, though. Treatment's about managing it, slowing it down, keeping things working.
Okay, so not a magic fix. Makes sense. But this IS, interesting. First-line treatment, the American College of Rheumatology, they actually recommend acetaminophen.
Yeah, surprised a lot of people.
Right. You'd think something stronger, wouldn't you? Why is that?
Long-term safety. NSAIDs, ibuprofen, naproxen, good for pain, but more side effects, especially long-term. Stomach ulcers, kidney stuff, not good. Acetaminophen's generally safer for the long haul, especially chronic like OA.
Makes sense. Got to think long-term.
Exactly. But treatment's not one size fits all. Corticosteroid injections for those bad flare-ups, physical therapy to strengthen everything around the joint, and if it's really bad, joint replacement.
Okay, lots of options depending how bad it is. So we talked wear and tear, but what about when it's inflammatory? Rheumatoid arthritis, RA.
Different beast entirely, not wear and tear. This is the immune system attacking the joints. And it's systemic, so it's the whole body potentially.
Whoa, the body fighting itself.
Yep. Starts with that synovial membrane, the joint lining gets inflamed. Then it all goes downhill from there. Cartilage, bone, damage, like a slow fire burning it up.
Yikes. So RA, couple big differences from OA, right?
It's younger, usually 30 to 50, women more than men. And unlike OA, which can be like one side worse than the other, RA is usually symmetrical. Both sides of the body, same joints.
Okay, so that's a clue. What about diagnosing it, though? It's not just if there's pain, right?
Nope, whole bunch of stuff. Morning stiffness, this is key. Lasts over an hour, that's bad. Joint pain, obviously, swelling, and eventually you get deformities, hands especially.
Sad to hear that, but makes sense. But here's a weird one. The DIP joints, fingertips, they're usually spared in RA. Why does that matter?
Helps us tell it apart from other arthritis types. Little detailed, but important.
So it's symptoms, blood tests, x-rays, whole puzzle.
Right.
But once you know it's RA, what then?
Gotta slow that inflammation down, it's going wild. And this is key. RA treatment, it's not just symptom relief. We're trying to change the disease itself. Enter DMARDs.
DMARDs. Okay, break that down for folks.
Disease-modifying antirheumatic drugs. We've got NSAIDs still, pain and inflammation like OA, but with RA, we add this whole other arsenal. Traditional ones like methotrexate, newer biologics, even non-biologic.
Lots of options, huh? So it's not pick one and you're done.
Often it's a combo. Control inflammation, slow the joint destruction. Balance it for each person, benefits, risks. It's personalized.
And physical therapy, I'm guessing that's in the mix, too.
Absolutely. Keeping those joints working, strength, flexibility, teaching folks how to live with RA. It's a team effort.
Because RA, it's chronic, right? It's there to stay.
Sadly, yeah. No cure yet. So treatment's about managing those flares, slowing it down, and helping people have good lives despite it.
Okay, that's RA in a nutshell then. But we said juvenile arthritis, kids. That's a whole other thing, right?
Oh, yeah, different story.
So juvenile idiopathic arthritis, JIA, most common in kids. Sounds heartbreaking, honestly.
It is. Chronic joint inflammation, and just like RA, it can be systemic. Hits organs beyond just the joints. Growth and development can get messed up, so early diagnosis, treatment, that's huge GE.
Got to be so careful with the little ones.
Absolutely. And it's not just one thing, JIA. It's a family of conditions, each with its own quirks. You've got systemic JIA, hits suddenly, high fever, salmon pink rash, joint pain. dramatic.
That's scary.
Then there's posteoarticular, few joints, and polyarticular, multiple joints, like adult RA.
Okay, so different flavors of the same bad thing.
Kinda, yeah. And diagnosing it, it's tough. No one tests symptoms, lab results, ruling other things OUT. It's like detective work.
Makes sense. But once you DNO, treatment's similar to RA, right?
Yeah, the goals are manage the inflammation, protect those joints from damage, improve their life. Methotrexate, maybe, physical therapy, occupational therapy too. It takes a village.
Sounds like JIA treatment. Got to be extra careful with kids and meds, side effects and all.
Oh, for sure. Dosing's tricky, watching for side effects constantly. It's a balancing act.
Yeah.
UT, the good news. Lots of kids with JIA, they go into remission.
Oh, thank goodness. That's a relief to hear. Okay, so we've done OA, RA, the big ones, JIA for kids. But that's just the start, arthritis-wise. Quick tour of a few others, just so folks have the overview.
Sure, let's do it.
First one's kind of out of left field. Infectious arthritis or septic arthritis. This isn't wear and tear. This isn't immune system gone haywire. This is bacteria in the joint.
Yeah, bad news bears. This one's sudden, terrible pain, swelling, redness, fever, the works. Usually Staphylococcus aureus, that one. Or even MRSA, the tough one to kill with antibiotics. Got to get on those IV antibiotics fast or it's permanent damage.
Yikes. Okay, so if it's sudden, BAD, that's a red flag.
Definitely. Now remember psoriasis, the skin thing. It's got a cousin, psoriatic arthritis. And here's the kicker. Joint symptoms, they can actually come before the rash.
Sneaky. So you might have it brewing and not even see it on your skin yet.
Yep, that's the tricky part. And the swelling, especially fingers, gets so bad they look like sausages. No kidding.
Oof. Okay, not a good look. Treatments for both skin and joint stuff, then I assume.
Yep, both sides. Meds, physical therapy, the usual combo.
Makes sense.
Yeah.
All right, ready for a medical mystery? Reactive arthritis, it's also called Reiter syndrome. This one's a delayed reaction to an infection somewhere ELSE in the body.
Weeks after the original infection's gone, even. It's like the immune system got confused, decided to attack the joints late to the party.
Wow. Talk about holding a grudge. What triggers it usually?
Sexually transmitted infections like chlamydia or those gut infections. Big joints, usually. Knees, ankles, and it's mostly guys who get it.
Interesting. Any reason why men specifically?
We don't know for sure, but there's a gene, HLA-B27. Lots of folks with this type of arthritis have it.
So genetics might be playing a role.
No.
Okay. Treatment's got to be two-pronged then.
Yep. Ease the symptoms, usually NSAIDs for that, and tackle whatever infection's still lurking if there is one, antibiotics.
Makes sense. Got to hit both angles.
Yeah.
Okay, on to a condition with, shall we say, a fancy reputation.
Gout.
Ah, yes, gout. This one's all about uric acid. Normally it gets filtered out, kidneys doing their job. But with gout, levels get too high. It's like tiny shards of glass forming in the joints, causing all that inflammation and pain. And the classic image, everyone knows it, someone clutching their big toe, agony.
It's practically a cultural icon at this point.
Right, but it's not just a big toe. Other joints too, and those crystals, they can even build up under the skin, these chalky deposits called tophi. Not pretty.
So how do we tackle this uric acid problem?
Two things. Stop those acute attacks, the flares, A&D, prevent them in the future. Flares, we've got NSAIDs, good old reliable, and this med called colchicine, specifically for gout.
Okay, so short-term and long-term strategies.
Yep. Long-term, it's all about lifestyle changes, no two ways about it. Diet to reduce uric acid, so less red meat, shellfish, anything high in purines, weight loss if needed, and got to cut back on the booze. Alcohol's bad news for uric acid.
It always comes back to that, doesn't it? It does. But for some folks, meds are needed on top of that. Allopurinol's a good one, blocks uric acid production, keeps those crystals from forming.
So working smarter, not harder. Now, Gail's got a twin, sorta. Calcium pyrophosphate dihydrate deposition disease, CPPD, called pseudo-gout often because it's MIMICS gout, but different crystals.
Instead of uric acid, it's calcium pyrophosphate crystals. Different shape under the microscope, that's how we tell them apart.
Okay, so same idea, different villain.
Pretty much. Gout loves the big toe. Pseudo-gout's more knee, wrist, elbow. It can flare up suddenly like gout, B-U-T. Can also be chronic, slow and steady, damaging joints like OA.
Two-faced, huh?
Kinda. And here's the kicker. Those CPPD crystals, sometimes they're just hanging out in the joint, no A symptoms. Then, bam, out of nowhere, you get a flare.
Tricky to diagnose then.
It can be. Treatment's similar to gout, though, pain and inflammation control. Knowing the difference is what lets us personalize it.
So, lots of overlap. But subtle clues matter. Okay, that's the arthritis roundup. But rheumatology is more than just joints, right? Connective tissues, that's a whole other world of problems.
Oh, yeah, those essential building blocks holding us together. When they go wrong, It can get messy.
First up, a real shapeshifter of a disease. Systemic lupus erythematosus, SLE.
Chronic autoimmune, this one, meaning the body's attacking itself, but multiple organs, not just joints.
So it's a widespread internal war.
Pretty much. And SLE, so many ways it shows up. Diagnosis is tough. Classic one, the butterfly rash across the cheeks, sun sensitivity, joint pain, swelling, fatigue, fever, on it goes.
Sounds miserable.
It can be. And way more common in women, childbearing age especially, African-American women even more so.
Yeah. Wonder why it is. Okay, but diagnosing it, no one test right.
Nope, gotta look at everything. Symptoms, lab results, rule, other stuff, OUT. There's specific criteria, need at least 4 to be sure it's SLE.
Like a checklist. And that ANA test we talked about for JAA, it's used here too, right?
Yep. Anti-nuclear antibodies, lots of autoimmune diseases have them. But certain patterns are really suggestive of SLE.
So clues within clues.
Exactly. And even when you know it's SLE, it's unpredictable. Remission, then flares, different organs each time.
Sounds like a roller coaster.
It is. So gotta monitor regularly. Stay ahead of it.
Yeah.
Sadly, no cure for SLE either. We're managing symptoms, preventing flares, protecting those organs long term.
Tough battle.
It is. NSAIDs sometimes, antimalarials, corticosteroids, even immunosuppressants. Depends how bad it is, what's being affected.
So really personalized.
Yeah.
That's where a good rheumatologist comes in, I guess.
Oh yeah, they're like the conductors, figuring out which treatment to use when.
Now let's talk about a condition that targets muscles directly. Polymyositis. Autoimmune again. But instead of joints, it's skeletal muscles, the ones we use to move.
And when those get inflamed, weak, it's even simple things. Getting dressed, stairs, become huge challenges.
So not just pain, it's losing your ability to DO stuff.
Exactly. Comes on slowly, usually weeks, months. Starts in the proximal muscles, the ones closer to your core.
Okay, so like lifting your arms, getting out of a chair, even holding your head up.
Yep, all that becomes hard. Symmetrical usually, both sides equally. Muscle pain, tenderness, fatigue, even swallowing gets difficult if those muscles are hit.
Oh man, that's awful. Any visual signs?
Sometimes, yeah. A purplish rash around the eyes, it's called a heliotrope rash.
Huh. So skin's involved sometimes too. And this one's also more common in women.
It is, usually between 30 and 50.
So diagnosing this, what's involved?
Blood tests, muscle enzymes go up, sign of damage. Electromyography, that's measuring the electrical activity, see if it's abnormal. And sometimes a biopsy, look at the muscle tissue directly under a microscope, be absolutely sure.
Okay, so 3 main ways to check it out. And treatment once you know it's polymyositis.
Gotta calm that immune system down. A&D, get those muscles working again. So high-dose steroids, knock down the inflammation, then methotrexate or other immunosuppressants, keep it in check.
And physical therapy's got to be crucial here too, right?
Huge. Retrain those muscles, build strength, improve function. It's a long process, but with the right treatment, lots of folks get a lot of their strength back.
That's good to hear. Okay, now on to one that gets confused with other stuff. Polymyalgia rheumatica. PMR. Pain and stiffness. But it's not the joints directly, it's the stuff around them. Muscles, tissues, especially shoulder and pelvic girdles.
Yeah, like a deep ache wrapping around those big muscle groups.
Makes those areas hard to move them.
Absolutely. And PMR, a couple of key things to remember. Hits over 50s mostly. Women more than men. And that stiffness, it's way worse in the morning. Like you suddenly age 20 years overnight.
Dad, I can barely get out of bed stiffness.
Exactly. And tricky thing is, mimics other stuff, fibromyalgia, arthritis. But PMR, you often have systemic symptoms too, not just stiff. You feel sick, fever, fatigue, weight loss, like a flu on top of it.
Oof, not fun.
And the big worry.
Yeah.
Gotta be sure it's not giant cell arteritis. Similar, but way worse. Affects arteries in the head, can cause blindness.
Scary. So how do they tell them apart?
ESR, erythrocyte sedimentation rate. It's a blood test, measures inflammation. PMR, it's SKY high, way more than those other conditions.
So ESR is a big clue then.
It is. And luckily, PMR responds well to treatment. Corticosteroids are the go-to. Zap that inflammation quick, feel better, function better.
So manageable, even if not curable.
Exactly. Big relief for folks struggling with it.
Now, onto a rarer one, but dangerous. Polyarthritis nodosa, PAN. This is blood vessel inflammation, small and medium-sized arteries, the ones delivering oxygen and nutrients everywhere.
Yeah, not just joints, muscles anymore. This is the plumbing itself getting attacked.
Yikes. And since those arteries go everywhere, PAN's got to be unpredictable.
You got it. Skin, kidneys, nerves, muscles, gut, anything's fair game.
Tough to diagnose that.
Nightmare, fever, weight loss, abdominal pain, neuropathy, skin lesions. even high blood pressure. It could be anything.
So doctor's got to be Sherlock Holmes here.
For real. Ruling other stuff out, often needing a biopsy, look at the tissue directly. That's the only way to be sure.
Wow, serious stuff. And treatment, once they figure it OUT.
High-dose corticosteroids, our main weapon. Sometimes other immunosuppressants, too. Got to get that inflammation under control.
But the real danger is the complications, right?
You bet. PAN can be fatal if it runs wild. Early diagnosis, aggressive treatment, that's the key.
Okay, so awareness is crucial. Let's talk about one that might sound familiar. Systemic sclerosis, also called scleroderma, connective tissue disease, chronic one, all about collagen.
That tough stuff gives structure and support, right? Well, in scleroderma, collagen goes into overdrive. Buildup of scar tissue in the skin, organs, like the body's turning to concrete slowly.
So not just stiff, it's getting thicker, harder?
Yep, that's the key. Skin's the most obvious, but lungs, heart, kidneys, GI tract, they can all be affected.
Wow, that's a lot. Any early warning signs?
Raynaud's phenomenon is common. Fingers turning white, blue in the cold, like the blood vessels are spasming.
Yeah, I've heard of that.
Then you get joint pain, swelling, stiffness, heartburn, shortness of breath, even kidney problems down the line. It's a whole body ordeal.
So diagnosing this, same as those others, big picture stuff.
Pretty much. Symptoms, blood tests, sometimes a biopsy. No cure, unfortunately, but we can manage it, slow it down. Meds for blood pressure, inflammation, even suppress the immune system, all tailored to the person.
Lots of moving parts.
Yeah, and physical therapy, occupational therapy, those are huge EE for scleroderma too. Adapting to the changes, staying as independent as possible.
Okay, good to know. Now remember those exocrine glands, saliva, tears, sweat, all that. There's a condition specifically for them. Sjogren syndrome.
Autoimmune, of course. This time the immune system's targeting those moisture-making glands.
So it's like the body's drying up from the inside out.
Good way to put it. Glands can't produce enough, so dry eyes, keratoconjunctivitis sicca, it's called, and dry mouth, xerostomia. Awful. Can be really debilitating.
I bet.
And it can happen on its own, or along with other autoimmune stuff like RA, SLE.
So got to be on the lookout if someone's got those dry symptoms.
Yep.
What confirms the diagnosis?
Schimmer test, checks tear production, biopsy of the salivary glands, blood tests for specific antibodies, a few ways.
And any cure for this one?
Nope, not yet. Artificial tears, saliva substitutes, those help. Sometimes meds stimulate saliva or suppress the immune system, depends what works for each person.
Okay, last stop on this rheumatologic roller coaster. Fibromyalgia, chronic pain disorder, this one. And it's tricky, right? It's more than just pain.
Oh yeah, whole constellation of symptoms. Widespread musculoskeletal pain, fatigue like you ran a marathon just getting out of bed, sleep problems, brain fog, even mood disorders.
Sounds like it throws everything off.
It does. Often comes with other stuff too. RA, SLE, IBS makes it even harder to figure out. And it's way more common in women, so hormones, other biological stuff probably involved.
That mind-body connection again.
For sure. Diagnosing it, tough, no one test. Gotta rule other things out first. Rely on the patient's story, exam, check those tender points, specific spots that hurt when you press on them. Connecting the dots.
No easy answers with this one.
Nope. No cure either, sadly. But UT, we can manage it. Pain relievers, antidepressants for mood, any pain, sleep meds if needed, physical therapy, ND cognitive behavioral therapy, the whole shebang.
So lots of different approaches, all to get those symptoms under control.
Exactly. Empowering folks to take charge, even with a chronic, misunderstood condition like this. It's about improving life, even if we can't erase it completely.
All right, take a breath, everyone. That was a lot of arthritis and rheumatologic stuff. Next up, bone and joint disorders. Ready for round two?
Bring it on.
We'll start with a common duo, tendinitis and tenosynovitis. All about inflammation of the tendons, those tough cords connecting muscle to bone, and the key difference.
Where exactly that inflammation is?
Right, so how can someone tell if it's the tendon itself or that sheath around it? What are the clues?
Well, tendinitis, the pain, it's right over that tendon, and it's worst when you use that specific muscle. Like a guitar string overstretched hurts most when you pluck it.
Interesting analogy. So specific spot, specific movement, that's your tip-off.
Yep. Tenosynovitis is trickier, though. The inflammation's in that sheath, so the pain's more spread out. Might even feel some creaking, snapping as the tendon moves inside.
Yeah, it doesn't sound pleasant.
Not really. And both of these, often caused by those repetitive motions we do all the time. Athletes, musicians, even us on our computers all day.
So tiny stress is adding up, wear and tear on a microscopic level.
Exactly. Tennis elbow, carpal tunnel, rotator cuff tendinitis, all those prime examples of overworked tendons and sheaths.
Makes sense. But good news is, Most cases respond well to TLC.
For sure. Good old rice. Rest, ice, compression, elevation. Plus, NSIs for the pain. Sometimes a corticosteroid injection calms the inflammation right down.
So those are the basics, but physical therapy is important too, right? Not just rest and meds.
Absolutely. Can't emphasize that enough. It's about those muscle imbalances, flexibility, retraining how you move so it doesn't come back.
I hear so much about PT for these things. Why is it so crucial?
Think of it like this. Keep playing that same chord on the guitar with a bad string. It's just going to get worse. PT's like tuning that guitar, everything aligned, working right so you can play without pain.
Makes sense. It's about the bigger picture.
Mm.
Okay, onto another ache we all know and love. Bursitis. Per se, those little fluid sacs, cushions in the joints, right?
Yep. Reduce friction, bones, tendons, muscles all moving smoothly, like gel inserts in your shoes, easier on your joints with all the impact.
I can picture that. So bursitis, those cushions get inflamed.
Exactly. Like the gel insert sprung a leak, can't cushion as well. Pain, swelling, tenderness around the joint, overuse, repetitive motions, same culprits as tendinitis often.
Wear and tear strikes again.
It does. Trauma can trigger it too. Direct blow, a fall, anything like that. And just to keep us on our toes, infection can cause bursitis too. That's septic bursitis, different ballgame.
Okay, so how do you know if it's infected?
Any fever, redness, wump in the joint, see a doctor, ASAP. We're talking antibiotics then. Gotta fight those bacteria.
Serious stuff.
Yeah, but luckily most bursitis is not infected, responds well to the usual. Rice, NSAIDs, sometimes a steroid injection to calm things down.
So same playbook, different location. All right, now for a heavy hitter. Osteomyelitis. Bone infection. This is serious business.
It is. Usually bacteria, often our friend Staphylococcus aureus again. But how'd they get into the bone? Bloodstream, an open wound, even during surgery, sneaky little buggers.
Like they're invading the fortress.
Exactly. And some folks, they're easier targets. Weak immune system, diabetes, sickle cell anemia, anything that messes with blood flow makes it harder to fight them off.
Okay, so those folks got to be extra careful. What are the signs, though? How do you know it's more than just a bad bruise?
Pain's the first clue, but not the fleeting kind. This is deep, constant throbs, won't quit. Swelling, warmth, redness around the bone like a beacon.
Oh man, sounds awful.
And then the classic infection signs. Fever, chills, fatigue, body saying, hey, something's really wrong.
So ignoring it's not an option here.
Nope, this one can get bad fast. Bone damage, sepsis, that's a bloodstream infection, life-threatening, even amputation if it gets out of control.
Sobering reminder that bones, even though they seem so solid, they're living tissue, just as vulnerable as anything else.
Exactly. So gotta catch it early. Blood tests, look for infection signs, imaging, x-rays usually to see the bone, sometimes a biopsy, identify the exact bacteria causing the trouble.
Like CSI for bones.
Pretty much. And then 5e antibiotics, big guns, weeks of them usually. Sometimes surgery, get that infected bone OUT, give the antibiotics a fighting chance.
Sounds intense.
It is, long recovery, but luckily most folks with osteomyelitis, they recover fully. Human body's resilient, plus modern medicine helps a lot.
That's good to hear. Okay, on to a topic that always makes people nervous. Tumors. Neoplasms,
Yeah.
to be fancy. Bones can get them just like any other tissue, right?
Right, both benign, the non-cancerous kind, and malignant, the cancerous ones.
So good and bad news all in one.
Yep. And they can be primary, started in the bone itself, or secondary, meaning they spread from somewhere else. Lung, breast, those are common ones. Those are metastases, little bits of cancer that traveled and took root in the bone.
So like seeds that blew in the wind?
Kinda, yeah. And those secondary ones are way more common than primary bone tumors.
Important distinction. Okay, let's start with the good news then. Benign tumors, the ones that are more scary than dangerous. Common types. What should folks know?
Enchondroma's one, benign cartilage tumor. Small bones, hands, feet. It's like a bump, an odd shape in the bone.
Okay, so it's there but not spreading.
Right. Then there's lipoma, fat cell tumor. Those can be anywhere, sometimes even in bone.
Huh, interesting. What about those ganglion cysts? Aren't those near joints, tendons?
Yep, those count as benign tumors too, even though not from the bone itself. Annoying, can hurt, but they're not going to go rogue, spread, and cause big problems.
Good to know.
Then there's osteochondroma, a bony growth on the surface of a bone. Near growth plates, long bones usually, like an extra branch growing off the main one.
Okay, so a variety of ways these benign ones show up. But the key is they share some traits, right?
Exactly. Slow growing, usually painless, don't spread. Might cause a bump, a weird shape, but they're not invading and taking over.
So mostly cosmetic, not life-threatening.
Yep, unless they're pressing on something vital, causing problems that way. But still, any odd bump, any pain that doesn't make sense, get it checked out just in case.
Always better to be safe than sorry. Okay, let's talk about the bad news then. Malignant bone tumors. These are the ones that can get nasty.
Yeah, these are different. Unlike the benign ones, these can grow fast, invade nearby tissues, even spread to other organs through the blood or lymph system. They're on a mission.
Not good.
Not at all. A couple of key players here. Osteosarcoma, most common primary one, meaning it started in the bone. Hits kids and teens mostly, those fast-growing long bones. Aggressive one this is.
So that's the one you hear about most often.
Yeah. Then there's chondrosarcoma from cartilage cells. More common in adults, slower growing than osteosarcoma, BUT can still spread.
Okay, so slow and steady doesn't mean it's harmless.
Nope. Then there's Ewing sarcoma, mostly kids and young adults. Long bones, or the pelvis, grows fast, spreads easily. And lastly, multiple myeloma. This one's different. It's plasma cells, the ones making antibodies that go haywire. Affects multiple bones often, creates these holes in them, weakens them. Fractures happen easier.
So it's attacking the whole skeletal system at once.
Yeah. And all these malignant tumors, some common warning signs. Pain's the big one, but not like the benign kind. This pain's deep, constant, often worse at night. Doesn't care if you rest or pop painkillers.
Sounds relentless.
It is. Swelling, warmth, tenderness around the bones, same as benign. But with malignant, you get those systemic signs too. Weight loss you can't explain, fatigue, fever, body saying, hey, something's seriously wrong.
So if those show up, that's when you really worry.
Exactly. And remember how we said fractures can be a tumor sign? With malignant ones, it's even more likely. Bone's weak, so even a little bump or even NO injury, and it snaps.
Yikes, so that's a huge GGE red flag.
It is. Early diagnosis, early treatment, that's the best chance with these. So those symptoms, especially the systemic ones, see a doctor ASAP.
Don't wait around with this stuff.
Nope. We start with the story, the exam, looking for clues, then imaging, x-rays, CT, MRI, see the tumor, size, location, has it spread. But to be 100% sure what kind it is, gotta do a biopsy. Little sample, look under the microscope, that's the fingerprint.
Okay, so multiple steps to get the full picture.
Yes.
And treatment, I'm guessing it's intense.
Often, yeah. Surgery, remove the tumor, maybe part of the bone, sometimes the whole limb if we gotta. Radiation might be used too, kill those cancer cells, and chemo, powerful drugs, hit those rogue cells all over the body.
So it's a fight on multiple fronts.
It can be. Tough road, but cancer treatments are getting better all the time, so there's always hope. Key is, catch it early, hit it hard.
That's where being aware of the signs comes in, right?
Absolutely. Now, CREF, let's switch gears to osteoporosis, the silent disease. You don't know you have it until, bam, a fracture happens.
Yeah, that's what makes it so scary. It's all about bone mineral density, right? Like how strong the internal structure of the bone is.
Exactly. Higher density equals stronger bones. Osteoporosis is when that density goes down. Bones get fragile, break easily, even with minor bumps and falls.
And it's not just about getting older, is it?
Nope, there are different types. You have primary osteoporosis, the most common kind linked with aging. It's like natural wear and tear as we age.
Okay, so just part of getting older.
Sadly, yeah. But then there's secondary osteoporosis. That's from other conditions or medications. Hormonal problems, certain meds like corticosteroids, lifestyle choices like smoking or too much alcohol, those speed up bone loss, up the osteoporosis risk.
It's not just about birthday candles then, it's about these other factors.
Exactly. And don't forget about the gender difference. Women are more at risk, especially after menopause. Estrogen levels plummet.
Oh.
Estrogen protects bone, so when it dips, bones become more vulnerable.
Makes sense. But this is the sneaky part. There are usually no symptoms until a fracture happens. It's like a ticking time bomb.
That's the danger. People think their bones are fine, then they trip, cough, something simple, and snap, there goes a bone. Hip, spine, and wrist are the usual spots.
So it's a rude awakening when that first fracture happens.
It is. Highlights why early detection and prevention are so important. That's where the DEXA scan comes in. Bone mineral density test. It's simple, painless, uses low-dose x-rays to measure the density in the hip and spine. Gives us a snapshot of your bone health.
So if a DEXA scan shows low density, what then?
Time for action. Protect those bones, prevent future fractures. Two-pronged approach. Building bone back up and stopping further loss.
So it's a two-front war.
You got it. Healthy lifestyle is the foundation. Enough calcium and vitamin D, those are building blocks. Weight-bearing exercises, walking, jogging, dancing, those stimulate bone formation, make you stronger and better balance. And as always, ditch the cigarettes, limit the alcohol, those make a big difference.
Everyday choices for a stronger skeleton.
Exactly. For some people, medications are necessary, slow down bone loss, even increase density. But it's not just popping pills, it's about a whole plan, personalized to you, your risks.
So it's not one size fits all.
Definitely not. And remember, preventing fractures isn't just about bone strength, it's about preventing those falls in the first place.
So thinking ahead.
Yep. Make your home safe, no tripping hazards, grab bars in the bathroom, good lighting, get your eyes checked regularly. Simple things, but they can prevent a lot of heartache.
It's about being proactive. Okay, let's shift gears now and talk about some common injuries. Fractures, dislocations, sprains, strains, all that fun stuff. Starting with fractures, which are, simply put, breaks in a bone.
And those breaks can happen in all sorts of ways.
I bet. Trauma, like a car accident or a bad fall, those are obvious.
Sure, but overuse, especially in athletes, leads to stress fractures, those tiny cracks from repetitive stress on the bone. And of course, osteoporosis makes fractures more likely. Bones are weaker, break easier, even with minor trauma.
It's like that delicate china you're afraid to touch.
Exactly. When it comes to fractures, it's important to know the different types because treatment depends on that.
Okay, break it down for us.
So you have closed fractures, skin's intact, and open fractures where the bone pokes through the skin. Open fractures are worse, higher infection risk because that bone's exposed.
Ouch, that sounds nasty.
It is. Then there are comminuted fractures, the bone's shattered into multiple pieces, and green stick fractures where the bone bends and cracks but doesn't fully break. That one's more common in kids. Their bones are more flexible, like a young tree branch.
Yeah, tense.
Lastly, stress fractures. We talked about those. Tiny cracks, repetitive stress. Runners get them a lot. They're sneaky. Pain builds gradually.
So not always a sudden dramatic snap.
Nope. So how do you know if you've broken a bone? Pain's the first sign, obviously, but it's not a normal ache. This is sharp, intense, worse with movement.
Ouch.
Plus, the usual, swelling, bruising, tender and lisse around the area. Sometimes you can even see the bone sticking out. The limb might be bent wrong, shorter than the other side.
So sometimes it's pretty obvious.
It can be. If you think it's a fracture, most important thing is to immobilize the area, don't move it, and get to a doctor, ASAP. Don't try to tough it out.
So no heroics.
Nope. Broken bone needs to be set right so it heals right. Immobilization prevents further damage, eases the pain. Casts, splints, slings, whatever it takes to keep those bones from moving around.
So those are the first aid basics.
Exactly. Sometimes surgery is needed. Put those bone fragments back together, hold them in place with plates, screws, rods, pins, like a tiny construction project.
Sounds intense.
It can be. But after that, whether it's immobilization or surgery, comes the rehab phase. Physical therapy is the star here, getting that strength back, range of motion, function. It's about guiding those muscles and joints back to normal, slowly and carefully.
It's a team effort then. Doctors, PTs, and the patient, all working together to rebuild.
Exactly. Teamwork makes the dream work. Now let's talk about dislocations. That's when the bones in a joint get knocked out of place. Not a break in the bone itself, but it's still a big problem.
Okay, so the puzzle pieces aren't fitting together anymore.
Right. Dislocations, just like fractures, often happen from trauma. Falls, sports injuries, even just twisting the wrong way, pushing that joint too far.
I bet those are painful.
Excruciating. Sudden, intense pain, swelling, it looks wrong, you can't move the joint at all. Definitely can't ignore this one.
I can imagine. Which joints dislocate most often?
Shoulder's the champ, then elbow, finger, and hip. Shows you how delicate that balance is, keeping those joints aligned and working right.
So what should you do if you think it's a dislocation?
Doctor immediately. Don't try to fix it yourself. That's a recipe for disaster. Get it checked out. Make sure there's no fracture too. X-rays are usually needed. Then a doctor can put those bones back where they belong. We call that reduction, often done under sedation because, it hurts.
Like solving a Rubik's Cube, but inside your body and with pain thrown in.
Pretty much. After that, immobilization, slings, splints, braces, whatever's appropriate. Gotta give those ligaments time to heal. They're the ones holding the bones together, keeping the joints stable.
Makes sense. Ligaments are the glue.
Yep. Once they've healed, physical therapy often, get that strength back, range of motion, and prevent future dislocations.
Okay, so prevention's key, as always. Now, let's tackle sprains and strains, two injuries that often get lumped together. Sprain is a ligament injury. those tough bands connecting bones, while a strain is a muscle or tendon injury.
Both of those support structures, but sprains are about joint stability, strains are about movement.
So sprained ankle, classic example, that's ligaments. Pulled hamstring, runner's woe, that's muscle.
Exactly. And just like fractures and dislocations, sprains and strains can be mild or severe.
Makes sense.
Mild sprain, ligament stretched a bit. Severe sprain, it's completely torn. Same with strains, muscle can be slightly pulled or totally ripped. Treatment depends on how bad it is.
So mild ones, what's the usual?
Rice again, our best friend. NSAIDs for pain. For those bad sprains and strains, physical therapy is essential. Get that strength back, flexibility, relearn how to move right so it doesn't happen again.
It's about getting back to normal, but doing it the right way.
Exactly. Now, let's move on to head and neck disorders, starting with TMJ disorder. Temporomandibular joint disorder. It's a mouthful, but it affects that jaw joint, the muscles controlling chewing, talking, all that.
TMJ, that's a common one. I've heard a lot of people complain about it.
It is. Pain, clicking, popping in the jaw, trouble chewing, even headaches and earaches that seem to come from nowhere.
What causes it?
Often it's multiple things. Stress can make it worse. Teeth grinding, clenching, those habits put pressure on the joint. Sometimes it's the teeth themselves, misaligned, that throws everything off.
So one problem can trigger others.
Like a chain reaction. Treatment's multi-pronged then. Conservative stuff first, rest, ice, soft foods, so you're not working that jaw too hard. Stress management is huge. Reduce that clenching and grinding.
And those mouth guards, dentists make them, those help, right?
They're lifesavers for some people. Reposition the jaw, cushion the joint, stop the teeth from grinding, like a little vacation for your jaw.
I could see that.
Yeah.
Meds help too sometimes.
Muscle relaxants, painkillers, those can give temporary relief. Physical therapy sometimes, strengthen the jaw muscles, improve range of motion, retrain those movements.
So it's a multifaceted approach.
It is. Now on to neck pain. That's something almost everyone deals with at some point.
Universal ailment, it seems.
It is. And neck pain is tricky, can mimic other things, hide its true cause. Could be muscle strain, sleeping wrong, too much time hunched over a screen. Those are simple. But it could also be a herniated disc, spinal stenosis, arthritis in the neck joints. Those are more serious.
So it's not always something that'll just go away on its own.
Definitely not. Symptoms are all over the place, too. Pain, stiffness, headaches, dizziness, even numbness and tingling down the arms into the hands.
Wow, so it can affect a lot more than just your neck.
Yep, it's those nerves getting irritated, signals going haywire. The key is knowing the red flags, the signs that something worse is going on.
So what should people be watching out for?
Fever, unexplained weight loss, weakness in the arms or legs, loss of bladder or bowel control, or that weird saddle anesthesia, numbness in the groin area. Those are bad signs.
Okay, so those are serious. See a doctor right away.
Absolutely. When someone comes in with neck pain, the doctor has to play detective. They'll ask about the pain, when it started, what makes it better or worse, any other symptoms.
So getting the full story.
Right. Then the physical exam, checking how well you can move your neck, feeling the muscles for tenderness, spasms, checking reflexes, sensation in the arms and hands. It's about building a complete picture.
Makes sense. And I'm guessing imaging comes into play too.
Often, yep. X-rays, CT scans, MRIs, those show the bones and soft tissues, rule out fractures, arthritis, herniated discs, anything structural. Sometimes nerve conduction studies are done too, see how well those nerves are working, make sure there's no pinched nerve or other nerve problem.
So it's a multi-pronged approach to diagnosis.
You got it. And once the cause is found, treatment can be specific to the problem.
So for simple muscle strain or stiffness, what's the usual?
Rice, the old faithful. NSAIDs for pain and inflammation. Physical therapy can be a huge help. Strengthen those neck muscles, improve flexibility, get your posture and movements back on track.
And what about those neck collars? I see people wearing those sometimes.
Those can be helpful short-term, immobilize the neck, reduce pain, especially after an injury like whiplash. But don't wear them too long, or those muscles will get weak, healing slows down.
So balance between support and movement, like with so many things.
Exactly. Sometimes stronger meds are needed, muscle relaxants, even opioids for severe pain. But those are tricky side effects, potential for addiction, not something to take lightly.
Definitely have to weigh the risks and benefits.
Always. And sometimes surgery is the answer. Herniated discs, spinal stenosis, those that don't get better with other treatments, surgery can relieve pressure on the nerves or spinal cord.
So surgery is a last resort, but sometimes it's necessary.
Exactly. Okay. Let's move on to the shoulder and upper extremity now. That's an area that's both amazingly mobile and prone to problems. We'll start with shoulder pain, a very common complaint, and the causes are all over the map.
Makes sense. The shoulder, so much range of motion, but that must mean it's less stable than other joints.
You got it. More mobile, less stable, more prone to injury. Shoulder pain, it could be something simple like muscle strain or tendinitis, or it could be something more complex, rotator cuff tears, frozen shoulder, even arthritis.
So lots of possibilities.
Mhm.
Like with neck pain, are there red flags for shoulder pain, things that mean you need to see a doctor right away?
Definitely. Sudden, intense pain, especially after a fall or injury, that's one. Weakness or numbness in the arm or hand, a feeling that the shoulder is loose, unstable, or if you can actually see that the shoulder looks deformed.
Okay, so those are the alarm bells.
They are. If you have any of those, see a doctor right away.
Don't mess around with those.
Yeah.
So someone comes in with shoulder pain, what's the first step?
Just like with neck pain, it's detective time. We ask all about the pain, when it started, what makes it better or worse, any history of injuries, activities that seem to trigger it.
Getting the whole picture.
Right. Then the physical exam, checking range of motion in the shoulder, feeling for any tenderness, muscle spasms, looking for weakness or instability. There are specific tests like the near impingement test or the Hawkins-Kennedy test. Those help us figure out if it's something like rotator cuff tendinitis or impingement syndrome.
So narrowing it down step by step.
Exactly. Based on all that, we might order imaging studies, x-rays, ultrasound, MRI to see inside the shoulder joint. X-rays show fractures, arthritis, bone problems. Ultrasound's good for seeing inflammation in the tendons or bursae. MRI gives the most detailed view of the soft tissues so we can see rotator cuff tears, labral tears, ligament injuries.
Like having x-ray vision.
Yeah. Now, let's go through some of the common shoulder conditions. First up, rotator cuff syndrome. This is a big one.
I've heard of that. It's about those muscles and tendons that stabilize the shoulder, right?
Right. You got it. The rotator cuff is a group of 4 muscles, and their tendons, they surround the shoulder joint, act like a support system, let you move your arm in all those directions, but also keep the joint stable.
Like a team of tiny weightlifters holding that shoulder together.
Perfect analogy. Rotator cuff syndrome is when those muscles or tendons get injured, inflamed. Could be mild tendinitis, could be a full-blown tear.
What causes those tears?
Often it's gradual, those repetitive stresses adding up over time. Think about athletes who do a lot of overhead movements like baseball pitchers or tennis players.
Right, those repetitive motions take their toll.
They do. But tears can also happen from aging. Those tendons just naturally weaken over time. And sometimes it's a sudden injury, a fall, direct blow to the shoulder, snap, that tendon goes.
So it can be sneaky or dramatic. What are the symptoms?
Depends on how bad it is. Tendinitis, you might have a dull ache, especially with overhead activities or at night. A tear, the pain's much sharper, more intense. You might even feel a pop or snap when it happens.
I can see why people wouldn't want to mess with that.
Nope. And no matter the cause, rotator cuff syndrome often leads to weakness, stiffness, those everyday movements, reaching, lifting, rotating the arm, all become difficult, painful.
So it can really affect your life.
Absolutely. If you think you might have a rotator cuff problem, see a doctor, get a diagnosis and a plan. Tendinitis or minor tears, conservative treatment might do the trick. Rice, NSAIDs, physical therapy to strengthen those muscles, restore normal movement.
So non-surgical options first.
Right. But for those bad tears, especially in younger, active people who need that full strength and range of motion, surgery might be the best way to go. Fix those torn tendons, get the shoulder working right again.
Okay, makes sense. What about shoulder dislocations? We talked about dislocations earlier. The shoulder seems like it would be prone to those.
It is the most common joint to dislocate. Remember the ball and socket joint? The head of the humerus, the ball, pops out of the glenoid cavity, the socket on the shoulder blade. Usually because of a forceful trauma, fall, sports injury.
Ouch, that sounds painful.
It is. Most common type is an anterior dislocation. The humeral head pops out the front. Think falling on an outstretched hand drives that head forward right out of the socket.
So the arm gets pushed forward and the bone goes, see you later.
Exactly. Posterior dislocations, where the head pops out the back, those are less common. Think direct blow to the front of the shoulder, car accident, contact sport. Something forces that head backwards.
Makes sense.
Those posterior dislocations can be tricky to diagnose. The deformity might not be as obvious. The arm might be held close to the body. Shoulder looks a little flat.
So doctors got to be extra careful. Consider that possibility, especially if there's a history of shoulder trauma.
For sure. And just like with any dislocation, shoulder dislocation needs immediate medical attention. Don't try to pop it back in yourself. That's asking for trouble. Get to a doctor, get x-rays to rule out any fractures. Then they can reduce the dislocation, put it back in place, usually done under sedation because, ouch, it can be very painful.
I bet.
After that, usually a sling for a few weeks, immobilize the shoulder, let those ligaments heal. Then, just like with rotator cuff tears, physical therapy is key. Regain strength, range of motion, retrain those movements, prevent future dislocations.
Okay, so similar rehab process. What about frozen shoulder? I've heard that one's a real pain.
Adhesive capsulitis is the official name. Bit of a mystery, this one. The joint capsule, that fibrous sac that surrounds the shoulder joint, it gets thick and tight.
It's like the shoulder is wrapped in shrink wrap.
Exactly. And that tightness restricts movement, leads to stiffness, pain, difficulty doing everyday stuff, reaching, lifting, rotating the arm.
What causes it?
That's the mystery. We know it often happens after a shoulder injury or surgery, almost like the body's trying too hard to protect that joint.
Overprotective, much.
Right. But sometimes it happens with no injury or surgery, so that's even weirder. And to make it even more interesting, frozen shoulder goes through 3 phases: freezing, frozen, and thawing.
Okay, walk me through those.
So, the freezing phase, it's all about pain. Comes on gradually, gets worse over time, deep aching pain, worse at night and with movement. As the pain gets worse, the shoulder gets stiffer, range of motion decreases. This phase can last a few months to a year.
Oof, not fun. What about the frozen phase?
Frozen phase, the pain might ease up some, but the stiffness is still there, makes it really hard to use your arm. Shoulder's stuck, doesn't want to move in any direction.
So you trade pain for stiffness. Not a great deal.
Nope. And this phase can also last for months. Makes everyday tasks a real struggle.
I can imagine.
It's frustrating for everyone, patients and doctors, because progress can feel so slow.
But there's hope, right? It eventually thaws.
It does, thankfully. In the thawing phase, that range of motion gradually comes back, shoulder loosens up, but the whole process from freezing to thawing can take a year, maybe even longer.
So patience is key. What about treatment? What can help with frozen shoulder?
It's all about managing the pain and getting that movement back. Pain relievers, NSAIDs, maybe something stronger if needed.
And physical therapy is probably important, right?
Huge. Physical therapy is essential for frozen shoulder, gently stretching that tight capsule, improving flexibility, strengthening the shoulder muscles.
And sometimes those corticosteroid injections can help.
Sometimes, yes, they can reduce inflammation, ease the pain, but they're not a cure-all.
Makes sense. And in rare cases, if nothing else works, surgery is an option. Loosen that tight capsule.
It's a last resort, but yes, most cases will eventually resolve on their own with time and the right treatment. It's just a matter of getting through it, being patient, and sticking with those exercises.
Okay, so good to know there's light at the end of the tunnel. Now, let's talk about a condition that can happen pretty suddenly and dramatically: rupture of the long head of the biceps tendon. The biceps, that muscle in the front of the arm, has 2 tendons that attach it to the shoulder blade. The long head tendon runs right through a groove at the top of the humerus, that upper arm bone.
It's like a rope going through a pulley, connecting that strong biceps muscle to the shoulder.
And in this condition, that tendon tears, either partially or completely. And those sudden tears, I'm guessing they're from forceful movements, those quick, powerful actions.
Right, weightlifter jerking up a heavy weight, tennis player smashing an overhead serve, that kind of thing.
Exactly. But sometimes it's more gradual, right, from chronic tendonitis or just wear and tear.
Definitely. That tendon can get frayed, weak over time, then even a small stress can tear it. And as with so many things, age is a factor. Tendons lose elasticity and strength as we get older, making them more prone to tearing.
So whether it's sudden or gradual, what happens when that tendon tears?
Usually pretty dramatic. People feel a sudden, sharp pain in the shoulder, sometimes a popping or snapping feeling. It's like something's let go in there.
Makes sense. And I'm guessing the usual suspects show up: swelling, bruising.
Yep. And sometimes there's a visible bulge in the biceps muscle, almost like a little knot or ball in the front of the arm. We call it a Popeye deformity.
So it's not just feeling it, you can actually see it sometimes.
Exactly. If you have these symptoms, especially after a sudden movement, or if you've had shoulder pain before, see a doctor, get it checked out.
And I'm guessing an x-ray is the first step.
Yep. X-ray can usually confirm the diagnosis and rule out anything else, like a fracture.
Yeah.
Might show a change in the tendon's position, maybe even a small bone fragment that got pulled off when the tendon tore.
Okay, so imaging helps get the full picture.
Mm-hmm.
Treatment for a torn biceps tendon, I'm assuming it depends.
It does. How bad is the tear, partial or complete? How old is the person? How active are they? Overall health, all that factors in.
Makes sense. It's not one size fits all.
Yeah.
So for a partial tear, what's the usual approach?
Conservative treatment might be enough. Ricey, pain relievers, physical therapy to help it heal and get that strength and motion back.
So no surgery, hopefully.
Hopefully not. But for a complete tear, especially in younger, active folks who really need that shoulder strength, surgery might be the best way to go. Reattach that tendon, get the shoulder working optimally again.
Okay, so surgery is an option if needed. Let's talk about some common shoulder and upper extremity fractures now. Starting with a fractured clavicle. The clavicle, that's the collarbone, right, connects the breastbone to the shoulder blade.
Right. It helps stabilize the shoulder, protect the nerves and blood vessels underneath.
Important bone, but it seems like it's pretty exposed.
It is. That makes it vulnerable, especially with falls or direct blows to the shoulder.
And those clavicle fractures, they're common, right?
Right.
Especially in kids and young adults.
Very common. They're always falling and bumping into things.
Playground mishaps, sports injuries, bike accidents, all that.
Exactly. And those fractures can be painful, sharp, stabbing pain, worse with movement, even breathing deeply.
So breathing hurts. Ouch.
Yeah, it can. And you often see swelling, bruising, tenderness around the fracture. Sometimes you can see the bone out of place, a bump or a droop in the shoulder.
It's pretty obvious something's wrong.
Usually, yes. If you think it's a clavicle fracture, immobilize the arm, usually with a sling, and get medical attention.
Don't try to walk it off.
No. An X-ray will confirm the diagnosis, show the fracture, how bad it is, and that helps determine the treatment.
So what are the treatment options?
Depends on the severity and location of the break. Simple fractures, just a crack, bones still aligned, a sling might be all you need. Just immobilize the arm, let the bone heal.
So give it a rest.
Exactly. For more complicated fractures, where the pieces are separated or misaligned, surgery might be needed. Put those pieces back together, plates, screws, pins, that kind of thing.
Another tiny construction project.
Right. And then, after the fracture's stabilized, whether with a sling or surgery, physical therapy is usually recommended. Get the strength back, range of motion, get that shoulder working normally again.
Rehab is a common theme, it seems. Now, what about AC separation?
Acromioclavicular separation happens at the AC joint, where the clavicle meets the acromion. That's the bony bump on top of your shoulder.
Okay, I can picture that.
AC separation happens when the ligaments holding that joint together get stretched or torn, usually from a direct blow to the shoulder, falling on an outstretched hand, that kind of thing.
So landing on your shoulder during a football game, falling off a skateboard, even just tripping and landing awkwardly.
Exactly. And like ankle sprains, AC separations are graded based on how bad the ligament damage is.
So how many grades are there?
6 grades. Grade 1 is a mild sprain of those ligaments. Grade 6 is a complete tear, often with damage to the muscles and tendons around the joint.
Okay, so a wide range of severity.
Yep. And the symptoms depend on the grade. A grade 1 separation might just be some mild pain, tenderness over the joint. Grade 6, we're talking excruciating pain, a visible deformity where the clavicle is sticking up and you can barely use your arm.
That's a big difference.
It is. And treatment, just like clavicle fractures, depends on how bad it is. For mild separations, grades 1 and 2, conservative treatment usually does the trick. Rice, NSAIDs, maybe a sling for comfort.
So similar to those simple fractures.
Right. But for the more severe separations, grades 3 to 6, surgery might be needed. Fix those torn ligaments, get the joint stable again.
Okay, makes sense. Now, what about fractures of the humeral head? I'm guessing that's the top part of the humerus, the bone in your upper arm.
You got it. The humeral head is that ball that fits into the socket of the shoulder blade, forms the shoulder joint. Fractures here are common in older adults, especially with osteoporosis. Those bones are weak, break easily, even with a minor fall.
So just tripping and falling on your outstretched hand can do it.
It can. And these fractures are painful. That pain often shoots down the arm.
Not fun.
Nope. Swelling, bruising, tenderness around the shoulder joint. Sometimes you can see a deformity. The shoulder looks droopy compared to the other side.
Okay, so there's some visual clues sometimes.
Yes. Suspect a humeral head fracture. See a doctor, get an X-ray, confirm the diagnosis, see how bad it is.
X-rays are the workhorse of orthopedics, it seems.
They are. Treatment for this fracture, same story as the others, depends on the severity, how much those bone fragments are out of place. Non-displaced fractures, the pieces are still lined up, a sling might be enough, let the bone heal. But for displaced fractures where the pieces are separated, surgery might be needed. Put those pieces back together. Plates, screws, pins.
Sounds familiar.
It is. After the fractures stabilize, whether it's with a sling or surgery, physical therapy is usually recommended. Regain strength, range of motion, get that shoulder working properly again.
Okay, so rehab is key. Again.
Always. Now on to humeral shaft fractures. These are breaks in the middle part of the humerus, the shaft, between the shoulder and the elbow. Direct blows to the arm, like getting hit with a baseball bat, falling on an outstretched hand, high-energy injuries like car accidents or gunshot wounds, those can all cause it.
Sounds like a lot of force is needed.
It often is. The symptoms are pretty standard for a fracture. Pain, swelling, bruising, might look deformed, can't use the arm properly. X-ray confirms it, shows those broken pieces.
Okay, so diagnosis is usually straightforward.
It is. Treatment, same as humeral head fractures, depends on the severity and displacement. Non-displaced fractures, a brace or splint might be enough. Keep the arm still, let the bone heal. But for displaced fractures, surgery might be needed. Put those pieces back together, hold them in place with plates, screws, rods.
So the toolkit's pretty similar for a lot of these fractures.
It is. And after the fracture is stabilized, physical therapy is essential. Get that strength back, range of motion, get the arm functioning normally again.
Rehab, rehab, rehab.
It's all about rehab. Now let's talk about supracondylar humerus fractures. This one involves the area just above the elbow joint.
That seems like a delicate area.
It is. Very common in children, usually from falling on an outstretched hand.
Classic kid injury.
It is. And these fractures can be serious because the brachial artery and the median nerve, those supply blood and sensation to the forearm and hand, run right through that area, so there's a risk of damaging those.
So it's not just about fixing the bone, it's about protecting those nerves and blood vessels.
Absolutely. Treatment depends on the severity and displacement, like the other humerus fractures. Non-displaced, a cast might be enough. Displaced fractures, or if there's nerve or blood vessel involvement, surgery is often needed. Realign the pieces. Hold them with pins or wires.
Okay, so it can get complicated. And afterwards,
Physical therapy, of course. Get that elbow and forearm working right again. Strength, motion, the whole 9 yards.
so lots of overlap in treatment for these fractures. Now let's move on to hand and wrist pain. That's got to be a common one, considering how much we use our hands.
It is. Hands and wrists, so intricate. All those bones, joints, ligaments, tendons, nerves, working together for those fine motor movements. We take it for granted until it goes wrong.
It's amazing how much we can do with them. But when something's off, it can really throw you off.
Absolutely. And the causes, just as varied as all the things we do with our hands. Arthritis, carpal tunnel, tendonitis, fractures, dislocations, nerve problems, the list goes on.
So it's a real detective job figuring out what's causing the pain.
It is. Starts with a good history, physical exam, like always.
Ask about the pain, when it started, what makes it better or worse, any other symptoms.
Exactly. Examine the hand and wrist, range of motion, tenderness, swelling. Check the feeling and strength in the fingers.
So hands-on detective work.
Yep. Then, depending on what we find, maybe some imaging, x-rays, ultrasound, MRI, get a better look. Sometimes nerve conduction studies check how those nerves are working.
Okay, so combining those clinical clues with technology to get to the bottom of it, let's talk about some specific conditions now. Carpal tunnel syndrome, that's one everyone's heard of, right?
It is all about that carpal tunnel, a narrow passageway in the wrist. The carpal bones form one side, the transverse carpal ligament forms the other, and the median nerve runs right through it. That nerve gives feeling to the thumb, index, middle, and part of the ring finger.
So it's a busy little tunnel.
It is. Carpal tunnel syndrome is when that nerve gets squeezed in the tunnel. Numbness, tingling, pain in those fingers, classic symptoms.
It's like the nerve is stuck in a traffic jam.
Good way to put it. And it's often worse at night, right?
I've heard that.
People wake up with numb, tingling hands, shake them, flex their wrists, try to get that nerve working again.
What causes that nerve compression?
Repetitive hand motions are a big one. Typing, using a mouse, gripping tools, playing certain instruments, all that puts stress on the nerve. Inflammation, swelling, narrows that tunnel even more.
So those everyday movements can really add up.
They do. And other things can contribute too. Pregnancy, thyroid problems, diabetes, rheumatoid arthritis, those can cause swelling that puts pressure on the nerve.
So it's multifactorial, like so many things we've talked about. What about treatment? What can be done for carpal tunnel syndrome?
Depends on the severity and the cause. Mild cases, conservative treatment often does the trick. Rest, avoid those aggravating activities, wear wrist splints at night to keep the wrist straight, NSAIDs for pain and inflammation.
Okay, so standard stuff.
Right. Sometimes corticosteroid injections into the carpal tunnel help reduce inflammation. but it's not a permanent solution.
Makes sense.
And for severe cases, or if conservative treatment doesn't work, surgery might be needed. Release that tight ligament, take the pressure off the nerve.
So open up that tunnel, give that nerve some breathing room.
Exactly. It's a pretty straightforward procedure, outpatient usually, and it can really make a difference for people with carpal tunnel.
That's good to hear.
Yeah.
Okay, now let's tackle decurvain tenosynovitis. This one's all about the tendons on the thumb side of the wrist, right?
It is. Remember tenosynovitis, inflammation of the sheath around a tendon. Well, in decurvains, the tendons that help move the thumb get inflamed. Those are the abductor pollicis longus and the extensor pollicis brevis. Causes pain and swelling on that thumb side of the wrist.
Those are some long names, and it's often from repetitive hand motions, just like carpal tunnel.
Yep, gripping, pinching, twisting, those little movements we do all the time without thinking.
And they can really irritate those tendons.
They can. Certain jobs or hobbies that involve those movements, gardeners, mechanics, musicians, even people who spend a lot of time on their phones, those repetitive thumb movements, that's prime decurvains territory.
So what are the signs that you might have it?
Pain on that thumb side of the wrist is the main thing. Sharp or achy pain. Worse with gripping, pinching, using the thumb.
So it really limits those everyday movements. What about treatment?
We start with conservative treatment, of course.
Yeah.
Rice, NSAIDs, a thumb spike splint to immobilize the thumb and wrist, let those tendons rest and heal.
Rest is so important for these types of injuries.
It is. Sometimes corticosteroid injections into the tendon sheath can help reduce inflammation, relieve pain, but again, it's not a permanent fix.
And if those conservative measures don't work, what then?
Surgery might be needed. Open up that tight sheath, let those tendons move freely again.
Okay, so surgery is always an option, but hopefully not the first one. Now let's move on to fractures and dislocations of the hand. The hand, with all those tiny bones, it's amazing how much we can do with it.
It really is. 27 bones, all those joints, ligaments, tendons, nerves. It's a masterpiece of engineering.
But all that complexity also makes it vulnerable to injury.
Unfortunately, yes. Falls, direct blows, crushing forces, those can all wreak havoc on the hand.
And those injuries can range from simple fractures to complex dislocations to those really bad crush injuries that damage everything. Let's talk about some of the common hand fractures now. First up, the boxer's fracture.
That's a fracture of the neck of the fifth metacarpal, the bone at the base of the little finger. It got its name because it often happens when you punch something hard like a wall or, well, another boxer.
Makes sense. Sounds painful.
It is. Swelling, bruising, tenderness in that area. And the little finger might be angled inward. That's the classic boxer's knuckle look.
So treatment depends on how bad the fracture is and how much the bone is out of alignment.
Exactly. Minor fractures, not much angulation. A splint or cast might be enough. Immobilize it, let it heal. For more severe fractures, or if the bone's really out of place, surgery might be needed. Put those pieces back together, pins, wires, that kind of thing.
Okay, so similar to those other fractures we talked about. Now, what about a Call's fracture?
That's a fracture of the distal radius, the bone on the thumb side of the forearm, just above the wrist. Usually happens from falling on an outstretched hand, that instinctive reaction we have to break our fall. Common in older adults, especially with osteoporosis.
So that weak bone thing again?
Yep. Classic sign of a Colles fracture is that dinner fork deformity. The hand's tilted upward and backward like the shape of a dinner fork.
I can picture that.
Plus the usual swelling, bruising, tenderness over the wrist. Treatment depends on the severity and displacement, just like the boxer's fracture.
Yeah.
Minor fracture, minimal displacement, a cast might do the trick. But if it's a bad fracture, or if the bone's really out of place, surgery is often needed. Plates, screws, pins.
Okay, so the theme continues. Immobilize it, and if it's bad, fix it surgically.
Exactly. And of course, after the fracture's stable, physical therapy is important. Regain strength, range of motion, get that wrist and hand working normally again.
Rehab is crucial. Now, on to a fracture that's often missed. The scaphoid fracture. The scaphoid, that's one of the little bones in the wrist, right?
It is. And it's notorious for being fractured when you fall on an outstretched hand. Problem is, it has a poor blood supply, so healing can be tricky.
So it's a bit of a fragile bone.
You could say that. And what makes it even trickier, those fractures don't always show up on x-rays right away.
So you could have a broken bone and not even know it.
It's possible. You might have pain, tenderness, but the x-ray doesn't show a clear fracture. And if it's missed or not treated properly, it can cause problems down the line. Non-union, that's when the bone doesn't heal right. Or avascular necrosis, that's when part of the bone dies because it's not getting enough blood.
That's scary. So doctors really have to be on the lookout for these scaphoid fractures.
Absolutely, especially if someone has wrist pain that doesn't go away after a fall. If we suspect a scaphoid fracture, even if the x-ray is not clear, we might order a CT scan or an MRI to be sure.
Makes sense.
Yeah.
Better safe than sorry with a bone that doesn't heal well. What about treatment?
Depends on the fracture, where it is, how bad it is. Minor fractures, a cast might be enough. Keep the wrist immobile, let it heal. More complicated fractures, or those that are likely to have non-union problems, surgery might be needed. Stabilize those bone fragments, help them heal properly.
Okay, so it can range from simple to complex, like with so many of these injuries.
It does. Now let's touch on hand dislocations. That's when those little bones get knocked out of place. Can happen at any of the joints in the hand, the finger joints, the knuckles, even the wrist.
And I'm guessing trauma's the usual cause, like with other dislocations?
Yep. Falls, direct blows, twisting forces, anything that pushes those joints too far. Symptoms are similar to fractures. Pain, swelling, deformity, can't move the fingers right. X-rays show us those bones out of place.
So, pretty easy to diagnose. Treatment's pretty standard too, I assume.
It is. Get those bones back where they belong. That's called reduction, usually done under local anesthesia so it doesn't hurt too much. After that, a splint or cast, keep it immobile, let the ligaments heal, stabilize that joint.
Makes sense.
And then, just like with fractures, physical therapy often follows. Regain that strength, range of motion, get the hand working smoothly again.
Rehab is such a crucial part of recovery. Okay, we've covered the hand and wrist pretty thoroughly. Let's move on to disorders of the back now, starting with the one that plagues so many people, low back pain.
The universal ailment. Something like 80% of adults will experience low back pain at some point in their lives. One of the most common reasons people go to the doctor, miss work.
You can really knock you down. And the causes are all over the map, right?
They are. Could be simple muscle strain, sprain, could be something more complex, herniated discs, spinal stenosis, arthritis, even more serious stuff, infections, tumors, those can cause back pain too.
So lots of possibilities. That makes diagnosis tricky.
It does. History, physical exam, those are always the first steps.
Ask about the pain, what makes it better or worse, other symptoms.
Exactly. Examine the back, posture, range of motion, muscle strength, flexibility. Feel for any tenderness, spasms. Check reflexes, sensation in the legs and feet.
So it's about gathering all those clues.
It is. Based on that, we might order imaging, x-rays, CT scans, MRIs, get a better look at the bones and soft tissues, sometimes nerve conduction studies, check how those nerves are working. It's about putting the pieces together, figuring out what's causing the pain.
And once you know the cause, treatment can be targeted.
Right. For most simple low back pain, conservative treatment's the first step. RICE, NSAIDs, physical therapy to strengthen those core muscles, improve flexibility, get those movements right.
Strengthening your core, that seems to be the answer for so many back problems.
It often is. Sometimes muscle relaxants are prescribed to ease those spasms, maybe a short course of opioids for severe pain. But those are tricky. Side effects, addiction potential, not something to take lightly.
Definitely have to weigh the risks and benefits there.
Absolutely. Other options include spinal manipulation, that's what chiropractors do. Adjust the spine can help some people. Epidural steroid injections, that's putting corticosteroids around the spinal cord, reduce inflammation, give some temporary pain relief.
So a few different tools in the toolbox.
We have options. But sometimes for severe cases or those that don't respond to other treatments, surgery might be necessary.
Like when?
Herniated disc that's pressing on a nerve, for example. Surgery might involve removing part or all of that disc, relieve the pressure. Spinal stenosis, we might widen that narrowed spinal canal, give those nerves more space.
So surgery is a last resort, but sometimes it's the best option.
Exactly. Now let's talk about sciatica. That's a specific type of low back pain that shoots down the leg, follows the path of the sciatic nerve.
Sciatica, I've heard people talk about that. It sounds awful. The sciatic nerve, that's the big one, right?
The biggest nerve in the body. Sciatica is usually caused by something pressing on that nerve, either in the lower back or as it runs through the buttock and down the leg.
So like a pinched nerve, but on a larger scale.
Good way to put it. Herniated disc is the usual culprit. Remember that jelly-like disc that cushions the vertebrae. When it bulges or ruptures, it can press on the nerve root, cause that radiating pain.
Makes sense. But other things can cause sciatica too, right?
Oh yeah, spinal stenosis, bone spurs, piriformis syndrome, even pregnancy can do it. Anything that puts pressure on that sciatic nerve.
So lots of possibilities. And the pain, I've heard, can be pretty intense.
It can be. Dull ache, sharp, burning pain can make it hard to walk, sit, even stand. Sometimes there's numbness, tingling, weakness in the leg or foot. That's a sign those nerve signals aren't getting through properly.
So treatment for sciatica, I'm guessing it depends on the cause, just like with low back pain.
You got it. Most cases, conservative treatment first. Rice, NSIA's physical therapy to get more flexible, strengthen those core muscles, maybe epidural steroid injections, reduce inflammation around that nerve root.
And sometimes simple stretches and exercises can help.
They can, but if that doesn't work, or if there's nerve damage, surgery might be needed to fix the underlying problem. Remove a herniated disc, widen the spinal canal, that kind of thing.
So multiple options depending on what's going on. Let's talk about scoliosis now. That's a sideways curvature of the spine, right? Instead of being straight, it curves, forms a C shape or an S shape.
Exactly. Scoliosis can be present at birth. That's called congenital scoliosis. But the most common type is idiopathic scoliosis, meaning we don't know what causes it.
So one of those medical mysteries.
It is, and it usually develops during adolescence, that time of rapid growth.
Makes sense, and it's more common in girls than boys, right?
It is, but we don't know why.
Another mystery.
Yeah.
So what should parents be looking for? How do you know if your child might have scoliosis?
Uneven shoulders or hips, that's a common sign. One shoulder blade might stick out more than the other. One hip might be higher.
Okay, so subtle things at first.
They can be. If you look at the child's back when they bend forward, you might see one side of the rib cage sticking out more than the other.
So if you see that, time for a doctor visit.
Definitely. A physical exam is usually all it takes to diagnose scoliosis. The doctor will have the child bend forward and look for any asymmetry or curvature in the spine. Sometimes an X-ray is done, confirm the diagnosis, measure the curve, helps decide the best treatment.
And treatment depends on how bad the curve is, the child's age, and how mature their bones are.
Right. Mild curves, we might just observe, watch it over time, see if it gets worse. Moderate curves, bracing might be recommended. Slow or stop the progression.
I've seen kids wearing those braces.
They're usually worn for several hours each day. Severe curves, surgery might be needed. Correct the curve, prevent more deformity. Spinal fusion's the most common surgery for scoliosis. That's joining two or more vertebrae together, straighten the spine.
So treatment can range from observation to surgery,
Right.
depending on the situation. Now, what about kyphosis? That's that excessive outward curvature of the spine, the hunchback appearance.
Right, kyphosis comes in different flavors, each with its own causes and characteristics.
Like what?
Postural kyphosis is the most common one. Just from slouching, poor posture, teenagers hunched over their phones, that's a classic example.
So it's a habit, something you can correct with some effort and maybe some exercises.
Exactly. But then there's Scheuermann's kyphosis, also called juvenile kyphosis. This one's a structural deformity of the spine, usually develops during adolescence.
So it's not just about posture, the bones themselves are shaped differently.
Right. The vertebrae, the bones in the spine, they don't form properly, become wedge-shaped, causing that forward curvature, and it can be painful, limit movement.
Sounds like it.
Then there's congenital kyphosis. That's present at birth, a problem with how the spine formed in the womb. And age-related kyphosis, that's from wear and tear on the spine, the discs degenerate, the vertebrae can fracture, all that can cause the spine to curve forward.
So kyphosis has a lot of different causes, depending on the age and the type.
It does. Treatment depends on the cause and the severity. Exercises, bracing, those might help in some cases. But for severe kyphosis, surgery might be the only way to correct the deformity and improve function.
Okay, so another condition with arranged treatment options. Now let's talk about spinal stenosis. That one's about narrowing of the spinal canal, right? That's space where the spinal cord runs.
Exactly. That narrowing puts pressure on the spinal cord and the nerves that branch off it.
That can't be good. What causes that narrowing?
Lots of things. Arthritis is a common one. Those bone spurs and thickened ligaments can encroach on that space. Herniated discs, those can push into the canal. Sometimes it's just part of aging. The discs naturally lose height, the ligaments thicken, the canal narrows.
So it's wear and tear, plus sometimes those other conditions on top of it.
Yeah.
What are the symptoms of spinal stenosis? What should people be looking for?
Back pain's a common one, but it's not always the main symptom. Leg pain, numbness, tingling, weakness, those can be more prominent, especially with lumbar stenosis. That's in the lower back.
So it can mimic sciatica in some ways.
It can, and the pain often gets worse with standing or walking, better with sitting or bending forward. That's because those positions open up the spinal canal a bit, relieve the pressure.
Makes sense. So how do you diagnose spinal stenosis? Is it just based on symptoms?
Symptoms are a big part of it, but we need imaging to confirm the diagnosis. X-rays can show us those bony changes, arthritis, bone spurs. MRI is better for seeing the soft tissues, the discs, ligaments, the spinal cord itself.
So imaging is crucial here. What about treatment? What can be done for spinal stenosis?
Just like with most back problems, we start with conservative treatment. Pain management, physical therapy to strengthen the muscles, improve flexibility, improve posture. Epidural steroid injections can help too, reduce inflammation, provide some temporary relief.
So similar to sciatica and low back pain.
It is, but for severe cases, or those that don't respond to conservative treatment, surgery might be the best option. We can widen that narrowed canal, take the pressure off the nerves and the spinal cord. Different techniques depending on the situation: laminectomy, foraminotomy, spinal fusion, those are some of the common ones.
So a range of surgical options depending on the specifics.
Right.
Okay, let's move on to ankylosing spondylitis now. That's a mouthful, but it's an inflammatory disease that primarily affects the spine, right?
It is chronic inflammatory disease. The main feature is inflammation of the sacroiliac joints. Those are the joints where the spine connects to the pelvis.
Okay, so it's not the whole spine. It starts in those specific joints.
Right. But it can affect other areas too: hips, shoulders, knees, even the eyes, heart, lungs in some cases.
Wow, so it can be systemic, like some of those other conditions we talked about? And it's progressive, meaning it gets worse over time.
Unfortunately, yes. That inflammation can lead to bone fusion. Those vertebrae actually start to fuse together, causing stiffness and limited mobility.
That sounds awful. Any idea what causes it?
Not exactly, but there's a strong genetic link. People with a specific gene, HLA-B27, are much more likely to develop ankylosing spondylitis.
So genetics plays a role, like with so many things. What about treatment?
Early diagnosis and treatment are important. Slow the progression, improve quality of life. NSAIDs are often used for pain and inflammation. DMARDs, those disease-modifying drugs we talked about for rheumatoid arthritis, those can be helpful too. And sometimes biologics are used. Those are newer drugs that target specific parts of the immune system.
So a range of medications to try to control that inflammation.
Right. And physical therapy is crucial. Keep those joints moving as well as possible, maintain flexibility, good posture.
So it's about slowing down the damage and maximizing function.
Exactly. Now let's talk about one last condition: cauda equina syndrome. This one's rare, but it's an emergency, requires immediate medical attention.
Okay, that sounds serious. What is it?
It's compression of the cauda equina. That's a bundle of nerves at the lower end of the spinal cord.
So kind of like a pinched nerve, but with a whole bunch of nerves at once.
All right. And it's usually caused by something big pressing on those nerves, like a large herniated disc, a tumor, trauma, even an infection.
But those nerves are getting squished, and that can't be good.
It's not. The symptoms are pretty alarming: severe back pain, problems with bowel or bladder control, numbness in the saddle area, that's the area between your legs, weakness or paralysis in the legs.
Those are definitely red flags.
They are. If you have any of those, get to a hospital immediately. This is a surgical emergency. We need to decompress those nerves, get that pressure off, or there could be permanent damage.
So time is of the essence. This is a good reminder to always pay attention to those red flags, those unusual symptoms, and get checked out if something doesn't feel right. Okay, we've covered a lot of ground here, from arthritis and connective tissue diseases to bone and joint disorders, fractures, dislocations, sprains, strains, the whole shebang. It's amazing how intricate and interconnected all these systems are. And it's a reminder that those seemingly simple aches and pains can sometimes be a sign of something more serious. So don't hesitate to seek medical attention if you're concerned. It's always better to be safe than sorry. Thanks for joining us for this deep dive into the world of rheumatology and orthopedics. We hope you found it informative and maybe even a little bit empowering. Remember, knowledge is power, and understanding your body is the first step to taking charge of your health. We'll see you next time for another deep dive into a fascinating medical topic.